it's appropriate for us to talk about hypotony in a curriculum on glaucoma. Patients with hypotony are often referred to glaucoma specialists to deal with them, and as glaucoma specialists, we cause a fair amount of hypotony. We can define this as an absolute number, for example, an intraocular pressure under 5 millimeters of mercury. And that's what's done in large randomized controlled trials like the 5-fluorouracil filtering surgery study. But more appropriately, for an individual patient, we can define hypotony as an intraocular pressure below which the eye does not function normally. So if I've done a trabeculectomy on somebody and they now a year later have an intraocular pressure of 4 millimeters of mercury but 20/20 vision and are asymptomatic, then I don't consider that to be hypotony. I consider that to be a success. Most cases of hypotony have an ocular cause, but there are systemic causes as well. And this is a listing of the ocular etiologies, and we'll go through each of them one by one. So if someone presents with hypotony, you first look at the limbus and see if you can find a bleb. Most people have had glaucoma surgery, a trabeculectomy, so you know that they should have a bleb. But people who've had other surgeries like extracapsular cataract surgery or even pars plana vitrectomy can have inadvertent filtration that forms a bleb. And those blebs can be very challenging to see. Sometimes we really actually have to open up the conjunctiva and pressurize the eye and Seidel test in the operating room to find an inadvertent bleb. Everyone with hypotony needs to have Seidel testing. So you can see as we're painting here, this flow of aqueous through the bleb, actually in multiple points here. Now, blebs will often glow a little bit because fluid is transuding through them, but if you actually see a little river like that, then that's Seidel positive. Patients with trauma or even sometimes surgical trauma can have a cyclodialysis cleft. This is a beautiful picture of a cyclodialysis cleft, and you can see that we're really just looking at the sclera here in this person who had trauma many years ago. Another cleft here. You can see that surrounding it is an area of angle recession, so we're torn into the ciliary body face in these areas, but right here the ciliary body has been pulled away from the scleral spur. And this on anterior segment OCT, again showing cyclodialysis cleft. These can be difficult to diagnose with gonioscopy because any pressure on the globe causes the anterior chamber to collapse when the pressure is very, very low. And so sometimes we need to take the patient to the operating room and fill the anterior segment with viscoelastic to try to identify areas of where there might be a cleft. This is a histopathology of a cyclodialysis cleft. You can see this space where the ciliary body has detached from the scleral spur and aqueous is just flowing into the suprachoroidal space where it's rapidly absorbed into the bloodstream. To me, it's interesting how similar this is to angle recession, where again there's tearing in the angle, but there is a wisp of ciliary body left behind, and so these patients obviously either have normal or elevated intraocular pressure. But if we erase this little tiny wisp here, then it would be cyclodialysis cleft. Retinal detachment, rhegmatogenous retinal detachment can cause hypotony. This is important for us as glaucoma specialists because some diseases like pigmentary glaucoma make people more likely to get a retinal detachment. And if we're following someone for glaucoma and they suddenly have a great pressure when we haven't done anything to cause it, then we need to be worried that they have something bad going on, a retinal detachment or a central retinal vein occlusion that can cause a pretty substantial hypotony. Ocular ischemia can cause hypotony, as can inflammation. There are systemic etiologies. Myotonic dystrophy, for reasons I don't understand, can cause bilateral hypotony. And if you have high serum osmolality from hypernatremia, uremia, hyperglycemia, acidosis, any of those things can cause hypotony bilaterally. And then what do we see? What are the sequelae of having a low pressure? You can have folds and Descemet layer. You can have corneal edema. You can have astigmatism because the tension of the lids is causing the cornea to bend. And this is really more of a problem in younger individuals who have some tone to their lids than it is in older individuals. The anterior chamber is shallow. You can have a cellular reaction and ultimately develop peripheral anterior synechia. So this is a flat anterior chamber and a hypotenuse eye. It's really important that checking the intraocular pressure in this eye might be a challenge because you could be applanating this patient's lens, and so you may get a spuriously very high reading. One can get cataract from hypotony, choroidal effusion, which can lead to suprachoroidal hemorrhage. You can have hypotony maculopathy, optic nerve head edema, or cystoid macular edema. So this is choroidal effusion in the far periphery. These are common and really not very concerning. They generally just will go away over time. And another choroidal effusion here on ultrasound, on a B scan. This is pretty scary, kissing choroidals. You can see the choroidal effusions are meeting here in the middle in this patient shortly after having an Ahmed Ceton performed. And on ultrasound, you would see this. You would see these massive choroidal filling with the retina kissing there in the middle. One can get hypotony maculopathy, particularly in young individuals. It seems that choroidal effusions are more common in older individuals and hypotony maculopathy more common in younger individuals. You can see all of these folds in the macula. Just another example of maculopathy, and on angiography showing the folds in the macula, and also on OCT. The optic nerve head can become swollen, and this can lead to pseudo-reversal of cupping. So the nerve on the left is somebody who has pretty profound glaucoma. After surgery, the pressure was very low. And on the right, this looks like optic nerve head reversal, but really this is just edema, this is just optic nerve swelling in a patient who's hypotenuse. This is not the recovery of the optic nerve like one might see in a child. These eyes can be uncomfortable, and they can ultimately develop ptysis. Treating hypotony is beyond the scope, I think, of this introductory curriculum. If one has a bleb leak, then that needs to be repaired. That is easier said than done. In fact, all of these things are easier said than done. One can do that by a number of mechanisms, including excision of the bleb and advancement of conjunctiva. If the eye is overfiltering, you can decrease filtration. That can be done by passing sutures through the scleral flap, backing down on steroids, and other ways of trying to get the pressure to increase. Repairing cyclodialysis clefts is a very challenging proposition, and obviously repairing retinal detachment would be done for reasons beyond just hypotony. One can drain the choroidal effusions. I believe that choroidal effusions are the result of hypotony and not the cause of hypotony. So often just draining the choroidal effusion is not sufficient to make the eye recover. But if one is in doing surgery to address a bleb leak or other issues, then draining choroidal effusions would certainly make sense.